for the nice opportunity. Um, when I looked at the session details, osteoporosis was given as a last topic. It's very apt because we don't screen for osteoporosis in our practice routinely, So it is often a neglected problem. Unless the patient comes with a fracture, we don't normally do or think much about it. That's a problem with osteoporosis. And to define osteoporosis, it's a systemic skeletal disorder characterized by low bone mass and microarchitectural deterioration of bone tissue with a consequent increase in bone fragility and susceptibility to fracture. So there is a problem with bone mass as well as the bone quality that leads to fracture, which leads to morbidity and mortality. Normally, as young children grow, until they reach the age of 30 years, the bone mass keeps on increasing. And then it gets stabilized between 30 to 50 years. For women, once they achieve menopause, which occurs early in Indian women, which you should notice. So the average age of menopause in Indian women is around 46 years. So from that point onwards, because of estrogen deficiency, they start losing their bone mass. And it's a very rapid downhill trend for the women. Whereas for men, it continues at the same level, peak level for another decade or so, and then start declining. So both men and women are getting affected by osteoporosis, but women get affected faster. If you need to know why we are bothered about osteoporosis, because it affects the population. 1 out of 2 postmenopausal women has osteoporosis, almost 50%. 1 out of 5 men above 50 years has osteoporosis. Osteoporosis prevalence increases with increasing life expectancy. People are living longer, naturally you'll be seeing more osteoporotic cases in your practice. After sustaining a hip fracture, there is a 20% mortality in 1 year. So once a hip fracture happens, naturally the patient's mobility comes down, patient can contract other infections, pulmonary infections and so on, and 1 out of 5 will die within 1 year. Hip fractures are followed by a 2.5-fold increased risk of future fractures. That's the other problem. And even after fracture, this is very, very important, even after the fracture, the patient gets admitted in the hospital, a good orthopedic team fixes the fracture nicely, but they fail to screen for the presence of osteoporosis, or fall assessments never get performed. This is the truth of the matter, and there is a lot of data available for this. What are the components of fracture risk? There are 2 components. One is the skeletal one, which is low BMD, anybody with low bone mass, bone mineral density, or anyone with previous history of fracture, in conditions where there is a high bone turnover, or when there is a family history of osteoporosis, then they have a higher risk. Whereas non-skeletal factors are often neglected. Whenever an older person with poor eyesight or poor hearing or poor balance is there, obviously their risk to fall is very high, and they have muscle weakness also. So we need to always address these factors also. So it is important to do a fall assessment at their home, because someone has to visit the home to see whether there are clutters in the floor which can be slippery, and slippery mats should be removed. Assistive devices like walkers, shower chairs should be provided, especially in people are old and they live all alone, and there should be grab bars in the restrooms. And osteoporosis is generally silent disease, so it doesn't come with a lot of symptoms, but people can present with some of the signs and symptoms, like having a stoop posture, or an astute physician might notice that the patient is losing weight or losing height over time, or trivial falls producing some fractures, or patient complaining of back pain. Generally it is silent. Who are the patients at risk? All postmenopausal women, those who are with low body weight, because people with low body weight have low bone density, and people who abuse alcohol or smoke cigarettes, and people with vitamin mineral deficiency, and all those who are immobilized. These are the people who are at a very high risk of developing osteoporosis. And there are other secondary reasons for osteoporosis, secondary medical conditions. The list is long, the slide is crowded. Not that we need to go through everything, but the important ones are highlighted. For example, we see a lot of patients with rheumatoid arthritis. They have a very high risk of developing osteoporosis. And people with hyperthyroidism or hyperparathyroidism and hyperthyroidism, and then people who are on glucocorticoid therapy. This is a common problem. So for different conditions, we prescribe steroid therapy, and these patients are at very high risk. Even after 3-4 weeks of steroid therapy, they can get into the early signs of osteoporosis. And we generally sign off our prescription with proton pump inhibitors. No? So the common use of the proton pump inhibitors that also can increase the risk. And chronic kidney disease patients have very high risk of developing osteoporosis. To understand how we treat osteoporosis, we need to know a little bit of bone remodeling, because there is always a microstructural damage which happens generally in the bones. Naturally, it need to be repaired. So osteoclasts, they chew the damaged area. So osteoclasts chew up the damaged area, and naturally that need to be filled up by new bone formation. That is done by the osteoblast. So whereas osteoclast activity is about 3 weeks only, it can show up within 3 weeks the damaged area, whereas the bone formation takes longer time. It's about 6 weeks. And there are good bone markers, multiple markers available, but then we use only 2 markers generally. One is P1NP to assess the bone formation, and CTX is for bone resorption. And when it comes to diabetic patients, it's a twin burden. So over 1/3 of otherwise healthy Indian diabetic patients have osteoporosis. Significantly higher proportion of fractures occurred in patients with diabetes. Diabetic patients with hip fracture had higher readmission rates compared to non-diabetics. And osteoporotic fracture risk is multifactorial in diabetic people because of advanced glycation end products, the medicines like canagliflozin or pioglitazone, chronic kidney disease, neuropathy, and the ease of fall, everything contributes. And bone mineral density is preserved in type 2 diabetes. Like this is a conundrum where their bone mineral density is good in people with diabetes, but the risk of fracture is increased due to the increased bone fragility. And how do we screen for osteoporosis? There is a FRAX score available. It's an online tool where you can download and enter the patient's detail. Even country specific FRAX tool is available. And unfortunately, in this FRAX tool, you cannot enter the status of diabetes. So, according to Thomas Paul, who is an authority from CMC Vellore, you have to enter, you have to click rheumatoid arthritis instead of diabetes. If your patient has got diabetes, you click rheumatoid arthritis and the risk score is valid. And DEXA scan is a gold standard. For all women who are over 65 years or men over 70 years, we can do. And younger postmenopausal, postmenopausal women or men 50 to 69 years based on their background risk factor profiles. So it is a high cost investigation, not that all patients can undergo this. So you have to be little choosy here. This is a standard spine and hip report. If the patient's value falls in the green zone, then they are normal. Otherwise, they have a problem. And this is a bone mineral density WHO classification. Normal is T score is more than -1. It's a standard deviation from the normal. Age matched controls around 30 years. And T score between -1 to -2.5 is osteopenia, something like your pre-diabetes. And T score anything less than 2.5 is considered osteoporosis. If your patient is less than 50 years, or if you think they have secondary osteoporosis, then you can look at the Z score. Otherwise, T score is normally used. And evaluation includes all basic things like calcium, creatinine, alkaline phosphatase, vitamin D levels, HbA1c, PTH whenever you plan to give teriparatide injection, bone turnover markers whenever they are under treatment, and X-ray, lumbosacral as well as thoracic spine lateral view, as well as DEXA scan. We have to start with the basics treatment. Maintain serum hydroxy vitamin D level more than 20 nanogram per ml in all patients with osteoporosis. So give them vitamin D supplementation of 1000 to 2000 IU, and then at least 1000 milligram per day of calcium, which can be from diet as well as calcium supplementation for all women more than 50 years. And there are two preparations available for calcium. One is calcium carbonate. It needs acid for absorption, so it has to be taken along with food, but it is cost effective. Whereas calcium citrate is a little expensive. It can be taken anytime, and we have to use such supplementation with caution in people with myeloma, CKD, or patients with history of renal stones. So who should be treated? Whenever you have a women population of more than 65 or men more than 70, or younger people with other risk factors, you do a DEXA scan, and with the T score is between 1 to 2.5, and if they have an increased fracture risk, then look at the FRAC score. If the 10-year fracture risk score is more than 3% for each fracture or more than 20% for major osteoporotic fracture, then they are candidates for treatment. If the DEXA scan score is straight away less than 2.5, or if they have already fracture, then straight away you go for treatment. And what happens when the FRAC score is less than 10%? You have to advise immobility. That means they have to be more mobile. You have to teach them weight bearing exercises. Smoking cessation is important, alcohol moderation, as well as avoid falls. They have to avoid ill fitting shoes, slippery mats should be removed, untreated Parkinson should be addressed, and postural hypotension need to be addressed. And these are the approaches of treating osteoporosis. Either you block the bone breakdown by giving anti-resorptive agents like alendronate, risidronate, or zoledronic acid or denosumab, or you promote bone formation by giving anabolic agents like teriparatide or abaloparatide. And anti-resorptives, post-menopausal women and men more than 50 years with DEXA confirmed osteoporosis are candidates for anti-resorptives. The other group which requires anti-resorptive are the people who are on potent glucocorticoids at high doses. So when it comes to treating patients with anti-resorptive, you have three choices. One is oral bisphosphonate, which is alendronate and risidronate. These to be taken in empty stomach in upright position. You have to instruct the patient, and then GI side effects are common. Contraindication include chronic kidney disease, pregnancy, esophageal disease, and rarely can cause atypical fractures. You can see on top the atypical femoral fracture, and top left is osteonecrosis of jaw, very rare complications. And if P1NP is suppressed, you have to give a drug holiday for 3 years. You cannot go on giving anti-resorptives at one go. So that's where the bone markers come in. And then zoledronic acid, it is becoming very popular because it's once yearly infusion. It's very easy to administer. And denosumab, it's a rankle inhibitor, a human monoclonal antibody. It has to be given subcutaneously every 6 months, can be used in CKD. That's the advantage. Even if the eGFR is less than 30, you can use denosumab, but there is no drug holiday. So you cannot prescribe this drug for a patient who is non-compliant. You have to have clear discussion with the patient that it need to be continued, and don't stop without subsequent anti-resorptive therapy also. This class also can cause atypical femoral fracture or ONG. Anabolic drugs include teriparatide, which is a synthetic PTH recommended for up to 2 years in multiple vertebral fractures, severe osteoporosis, and non-responders to bisphosphonate. It's a daily injection for 2 years. Every day the patient has to inject, and it increases the serum calcium. So you have to check the serum calcium and never start this drug in patients with hypercalcemia. After 2 years, always follow it up with an anti-resorptive therapy. Abaloparatide is a PTHRP analog, and when it comes to choice of therapy, if it is vertebral fracture, you straight away go for teriparatide for subcutaneous for 2 years, followed by anti-resorptives. Hip fracture, zoledronic acid, denosumab, alendronate. So anti-resorptive first, and then go for teriparatide. 1 minute. And high risk without any fracture, you go for anti-resorptives. And low to moderate risk without fracture, but still you want to treat, then alendronate oral, also zoledronate yearly once. So, in compared to diabetes, treating osteoporosis is a little different. We go for early combination therapy in diabetes, whereas in osteoporosis treatment, it is mostly sequential therapy. Like you start with anti-resorptive and go for anabolic and so on. So, it's a preferred option than the combination therapy. How do you monitor the therapy? You can do a BMD by DEXA at the spine and hip every 1 to 3 years, because DEXA is not going to give you enough information within 1 year. So there is no point in doing it after 6 months. So 1 to 2 years later you can repeat the DEXA. Alternative is you can monitor the bone turnover markers like CTX or P1NP, and monitoring is usually begun after 2 years of treatment. So there is no urgency to rush monitoring, and good response. You have a stable or increasing BMD in DEXA. Finally, to summarize, fractures due to osteoporosis are serious but eminently preventable. Osteoporosis affects both men and women, so never think that it's only women. And diabetes and osteoporosis, they are the twin burden after 5th decade of life. And fracture risk depend on many factors. It is multifactorial. You have to address all the factors, and lifestyle changes can slow down but cannot reverse the bone loss. So majority of the people may end up getting treated. When used properly, osteoporosis medications are safe and effective. Thanks for your patient listening.